Hello, and good afternoon to you on another nice day in the UK. We don't get these too often in a row, but bit of rain yesterday, but a bit of nice weather today. So thank you for giving up your time. And I'm going to tell you a little bit about pharmacogenomics and how it specifically relates to mental health. So I'm just going to share my screen as I have a presentation, and hopefully you will be able to see that now. So this is around personalized medicine, or part of precision medicine, terms that you might have heard of. It's about how can we use information about individuals to make their care journey much more specific and personalized to them. And pharmacogenomics, or PGX, because it's a bit easier to say PGX, can and is starting to transform patient care. And in this talk, as I said, I'm going to look specifically at mental health, also a little bit about clopidogrel, which is an antiplatelet agent, which we often use in patients who've had strokes. And there are a lot of stroke survivors in the UK, and many of those are on mental health medications. So that's the plan. So tell you a bit about myself. So I'm Dr. Mark Hudson-Peacock. I am the founder, chairman and CEO of Mantara Health Limited, which is a UK company which has launched the first CE marked and UKCA marked pharmacogenomic, or PGX, panel test, fully registered with the MHRA. Neither myself nor Mantara are receiving any remuneration from today's presentation. So what's my background? So I am a consultant dermatologist, and I'm currently the Chief Medical Officer for the Dermatology Partnership. That's a group that is owned by Bupa, and we are the largest consultant dermatologist-led clinic group in the UK. I'm also the co-founder and chairman of a company called Xroid, and today it's all about pharmacogenomics. So therapeutics, obviously as a doctor, I always prescribe medicines from when I started my journey a long time ago to the every day that I see patients, I'm prescribing something for them. So therapeutics has always been a passion for me. And with this knowledge, I wanted to get behind pharmacogenomics in the UK to drive better and safer prescribing decisions for patients, and introducing an evidence-based, validated PGX test and product to do just this, which is what Mantara Health have done. We have the Mantara PGX panel test. Sustainability is also a passion of mine, and pharmacogenomics feeds very nicely into this particular agenda. Reducing significant drug waste as just the tip of that particular iceberg. The whole thing leading into how important pharmacogenomics is the following statement, and that is that 90% of medications that we are prescribed only work as intended in under half of us. So that is really quite a significant thing. As a doctor, when I was training, I was told, these are the drugs you give for blood pressure, these are the ones for diabetes, these are the ones for pain. And my assumption was they worked in everybody. And the patients were getting them assumptions were they're going to work in me. However, we know more now, and genetics is really the key to unlocking the door of personalized medication prescribing. So quite exciting time. So as we already heard, 90% of drugs are effective in only 30 to 50% of patients prescribe them. And this is based on a publication in Nature in 2015, and then reported in a Telegraph article in 2022. 89% of patients, that's virtually 9 out of 10 patients age 70 and over, are taking at least one drug with a known genetic interaction. Commonly prescribed medications are ineffective or less effective for 46% of patients with depression, arthritis, diabetes and asthma. Almost half of patients are taking a product that does not suit them genetically. So finally, there is a study going on at the moment called the Progress Study in Manchester, and a preliminary report in one of the journals showed that 28% of patients prescribed proton pump inhibitors, that's for reflux, etc., antidepressants, clopidogrel, the antiplatelet agent, and statins to reduce cholesterol, changed their prescriptions after going through a pharmacogenomic panel test using just these 4 drug groups, which is a significant number of people. That's more than 1 in 4 patients on these drugs are changing their prescription following a pharmacogenomic test. So this is why pharmacogenomics is important. So we need to imagine a healthcare system where medical decisions are not based on a one-size-fits-all standard. And you can imagine if you've got a very small lady or a child, or not a teenage child, or a very large bodybuilding chap, a dose might not suit them, but everyone is given the same dosing. And that is, something we need to change. And it's quite obvious that that dose is not going to suit everybody on basis of their physical stature. But there are lots of other factors that will interfere as well, and that is the unique genetics, and that's where pharmacogenomics comes in, but also their lifestyle, their environment, and even socioeconomic factors can all impact on how a drug actually works. As a doctor, I've been there. I've watched patients struggle because of what I've tried the first time hasn't worked as expected. May have had to try a different drug if they've had side effects or it hasn't worked. And with pharmacogenomics now here, this is changing that narrative. It allows us as doctors to predict how well a medication might work in a patient based on their unique genetics. And this is part of so-called personalized medicine. How many patients experience unwanted side effects from a medication? That's a question that we want to know. And some of these unwanted side effects might include death at one extreme end of the spectrum. Well, we know from studies, and there was one done in Liverpool that was reported that showed that 16.5% of acute admissions through accidented emergency departments can be secondary to severe adverse drug reactions. Pharmacogenomics takes the guesswork out of prescribing, and it allows us to prescribe the right drug at the right dose, first time for the patient in front of you. What you might call the holy grail for prescribing has arrived, and it is going to change how we prescribe medicines forever, really starting now. Just last week, thinking about the pressures on mental health service, we know that there are challenges. And just last week at the Royal College of Psychiatrists International Congress, it was reported on doctors.net that Dr. Lade Smith, who is the president of that society, reported that psychiatrists are forced to navigate a mental health system stretched beyond its limits. In their article, she said that long-term underinvestment and a failure to follow an evidence-based approach has led to an erosion of standards in the mental health system. And the challenges of lots and lots of patients, lots of demand, and insufficient numbers of psychiatrists, insufficient people in the community to support with mental health is a massive challenge, along with all the other problems that the NHS has to face and deal with. So it's timely that the upcoming 10-year NHS plan, which is supposedly being presented by the Prime Minister today, is a perfect opportunity to craft a clear ambition for the prevention and treatment of serious mental illness as just part of that plan going forward. And within that, pharmacogenomics and using the pharmacogenomic tools to guide prescribing is really going to change the narrative when it comes to mental health care delivery. It's going to remove the trial and error approach to prescribing to a much more personalised one, specific for the patient in front of you and guided by their particular genetic makeup. So what is this going to achieve for the NHS and for the wider economy? Well, drug waste is going to be significantly reduced. And we know that there are challenges with some drugs being got hold of. It's not available, so you have to wait for that prescription to be filled. But the waste, if you can reduce it, then the medication that is available can be used by the right patients and not given to the patients in whom it's destined to fail miserably. It's going to potentially free up doctors' time, prevent wasted doctors' appointments, and taking mental health as an example. You may go to your GP or your psychiatrist and they may try a drug and see how it works. They'll gradually build up the dose. You may find you have side effects. You may find that it doesn't work. You may have significant side effects, and ultimately you have to come off that drug and try another one. That's the trial and error process that we currently live with. We want to change this and move it to a much more targeted medication based on knowledge of the genetics that we all have. And most importantly, as a consequence of using this approach, patients are going to be healthier more quickly. They can have improved quality of life. Their disease is going to be managed using the right medications at the right time and at the right dose. That is the promise of pharmacogenomics as part of precision personalised medicine. So what does this mean for us here in the UK and in the NHS and private healthcare settings? Well, Genetics has, in its broadest sense, been up to now seen as a specialist area practiced by clinical geneticists. But pharmacogenomics is different. It is now our ethical duty as doctors to offer pharmacogenomic testing to all patients, whether they're in the NHS or outside the NHS, because why wouldn't we offer it? Patients can then make a choice about whether they want that information, which they can be in charge of and share with whichever doctor they are with at that time, whether it's the GP, the psychiatrist, the cardiologist, the gynecologist. It doesn't matter. That information is the patient's information and could impact on the prescriptions that are given by any number of colleagues. And also, they've got that information when they fly off on holiday to wherever they fly off on holiday to. They've still got that information such that if they have a problem when they're abroad, they can see the medical teams and they can also see that information and make prescribing decisions based on that. So it's a useful tool for all of us as patients to have. And in the future, we will all have one. It's a no-brainer. It will be used by prescribers in both community and hospital settings. It's already part of the new pharmacy curriculum. So pharmacists who are trained in how drugs work, and obviously they are there to help dispense them as well. They are trained in the art of pharmacogenomics. However, it's not on medical curricula yet, and it needs to be. And I think as doctors and pharmacists are both collaborating and helping patients, with them both on the same page, it would be really helpful in moving pharmacogenomics forward at a more rapid pace. Why? Well, because the impact pharmacogenomics is going to have on the commonest medications we use today. And a recent study has shown that using PGX panel testing will impact at least 80% of patients over their lifetime. And that's looking at the 50 and overs. If you have it when you're younger, then the chances of it helping most people during their lifetime, well over 80%, is high. And even those of 70 years of age and over, it will help at least 75% of them having had that test through the rest of their life. So it's a test that's going to impact most patients at some point. Thence, in the future, it'll be when we're born, we'll have a pharmacogenomic test, amongst other things, and that will just become part of your record to help guide future prescriptions through your life that may become necessary. It will reduce adverse drug reactions. It will improve treatment effectiveness or efficacy. It will improve treatment safety, and it will encourage patients to take their medication. And we know that a lot of patients don't take their medication because they're worried about it or they forget about it, they have side effects from it. So getting patients to take the medication to help them is really important. We have a so-called yellow card system in the UK. So when somebody has a significant adverse reaction, we report it on this yellow card. And there was a study done recently that showed that 9%, virtually 1 in 10 of the 1.3 million yellow card reports could have been prevented by preemptive pharmacogenomic panel testing. This is a big number. The impact prescribing has on the carbon footprint as well is not insignificant. And we know that the NHS's contribution through drugs is around 20% of the carbon footprint. So because the NHS is aiming for carbon net zero by 2040, by getting prescribing more effective and more efficiently managed, and pharmacogenomics will be a tool to achieve that, it's going to impact significantly on that carbon net zero ambition. The cost savings, you can imagine, are potentially eye-watering and quick to realise as well. It's not a thing that might realise savings in 5 or 10 years' time. No, it will save money this year if it was implemented. Patients are increasingly going to demand access when they know about this. And why wouldn't they? I mean, I would, and I have. My wife has. And we've used our GP to change prescriptions and has impacted our benefit to our own benefit. It will also be helpful for ethnically diverse populations because they will receive benefit from implementing pharmacogenomics, as we are all different. And certain ethnicities have certain disadvantages with regards to health problems, but also can be, we can use pharmacogenomics to guide better prescribing for them. And I will say a bit more about that later. And the SPCs, these are the piece of paper that you have in your drugs when you get them. You open it, that's all the instructions. They already contain pharmacogenomic advice for some drugs, such as codeine, which is a common painkiller. Now, we know that some patients, if you have got a so-called CYP2D6 poor metabolizer status, codeine won't work for you because it can't. It can't be taken from being codeine, which is what we call a prodrug, into its active form within the body because the enzyme is missing because of that genetic variant. Alternatively, if you've got the variant that actually metabolizes it very, very quickly, you can essentially get an overdose of morphine by taking codeine. Because codeine is converted to morphine to have its pain-killing effect, and that in extreme cases can kill you. So it's a useful bit of information to know. So with everything that pharmacogenomics has to offer, why aren't we using it already? Well, prescribers, that's including pharmacists, doctors, and nurse prescribers, all need to be aware of and use this amazing tool for the benefit of the patients they're caring for. So why aren't they? Is it a lack of education and awareness? Absolutely. It's only just been introduced into pharmacy curriculum. It's not in medical curricula yet across the whole country. So the most junior members of the team, when they qualify, are not really that aware of it in medicine, a bit more aware of it in pharmacy. We need to increase that awareness, and education is an important part of that. Is it because it is too expensive? Well, it depends on what expensive is. Is it expensive for the system? Well, if you suddenly did a pharmacogenomic test on everybody, there is a cost relating to that, of course. But costs can be saved within year, as I said. So yes, it would be expensive, but you're going to realize the costs very, very quickly. And at the moment, because it's not available on the NHS, people can get it privately. So the Mantara test, just to be up front there, you can go online, you can buy one, it's £399. Is that expensive? Well, yes, it is for a lot of people, but no, it's not for others. And when you consider you only really need to have that test once because your genes don't change, it's not like having another sort of blood test or an X-ray or an MRI where you need to repeat them. This is something you're not going to need to repeat very often at all. And the only reason you might repeat it is if a new gene was found that was important, and then we might repeat it to answer that specific question about, well, what's that gene variant that I've got, and is it going to impact on any other drugs I might be prescribed? So yes, it is too expensive, maybe, but no, it's not. It's going to save money very quickly. Can our hard-pressed NHS healthcare system implement testing currently? No, it can't. That's an absolute reality. There aren't any labs in the UK that are currently able to provide the panel testing requirement at commercial scale. So we would have to change things very quickly and dramatically. And there are lots of very well-meaning people, myself included, who are talking to try and work out how are we going to do this. But it's going to take time. Is it too hard to do with all the other priorities within the NHS? Well, we only have to turn on the news to know what pressures we're under in terms of A&E, in terms of the other demands, in terms of waiting lists that people are waiting for their hip replacement. And that. Yes, there are a lot of priorities. And yes, layering this in is going to make it another priority, but is it going to be worth it? 100% for the reasons I've already mentioned. Is it because medical politics and our academics inadvertently slowing progress? Well, absolutely yes. It's trying to get through the layers of bureaucracy within the NHS to get the decisions made by those medical politicians to implement something is a challenge. But it's a challenge that we have to meet. And our academics inadvertently slowing progress? Yes, they do. They stifle the progress. I mean, very well-meaning. We want the information. We need the studies. But sometimes because studies are going on, other people don't make decisions because they're waiting for the results of the studies, even though there may be overwhelming evidence already there. So yes, there is some stifling of progress. Now, consider these facts. 8.7 million people in the UK were prescribed antidepressants in the year to March 2024. And if 46% of those do not work as intended in patients, this is a massive drain on resources. Wasted medications, ineffective treatment, added burden of hospital and clinic visits, let alone the effects on the patients, the side effects they might suffer, having to come into hospital and further burdening the system. As I said earlier on, 16.5% of admissions through A&E are due to adverse drug reactions. A lot of them will be people with mental health needs and who are on medications where they've had significant side effects. 1 in 4 people over the age of 25 will suffer a stroke in their lifetime. And there are 1.3 million stroke survivors in the UK, which costs the system around £26 billion a year. And this is estimated to increase to 75 billion by the year 2035. And many patients who are stroke survivors take antidepressants for obvious reasons. And so, these are massive, massive numbers. What is the cost of mental ill health in England? Well, there has been an estimate done in 2022, and it was around £300 billion a year. And this comprises of economic costs of around 110 billion, accounting for absenteeism, staff turnover, and unemployment factors. Human costs around 130 billion, with reduced quality of life and premature mortality. And health and care costs of 60 billion. That is around the public services and informal care from family and friends. So a massive bill for looking after people with mental illness in the UK. So let's come back to the pharmacogenomics. Where does this all start? What does it mean? Well, we have unique genetics, all of us. The only ones that have similar are identical twins, because they've come from the same genetic envelope. So what do drugs do? So all of these bases that we have that have this triple helix form that we all have learnt about, a drug can be prescribed, the one size fits all, the trial and error, and for some of us that drug will actually work. What it is, it's shown in that upper image there. The one green tablet works for that cartoon man. However, for some patients they might need 3 times the normal dose, or a number of doses higher, to have the same effect as in the second one there. And yet others, depending on your genetics, may only need half the dose to actually have the effect that you're after and reduce the risk of side effects. And then the last one, that red pill, that dose might be significant in terms of getting side effects, with the worst case one being death. And that is something that we want to try and avoid. But without pharmacogenomics to guide the prescribing, it's a case of try that, see if it works. It might work, you might need a higher dose, you might need a lower dose, it might at worst case kill you. So information that's really useful to understand. So in reality, this is a slide I have borrowed from Professor Steinberger in Germany, and this is talking about DNA variations and drug response. So about 1/3 of drugs that we prescribe will work as expected, and you'll have them fine and not have any problems. However, around 2/3 can have undesirable effects. As I said before, you can have a stronger effect, which might be toxic or lethal at one extreme, or give you adverse drug reactions or side effects on the other. Or the drug might not work as effectively as you would like it to, either reduced dose not working, or any dose not working because you haven't got the right genetic variant. And this is quite important to understand. So if a drug response is too strong or toxic, what can we do? Well, guided by pharmacogenomic variant knowledge in your report, we can reduce the dose to reduce the risk of that toxic or too strong effect and reduce the risk of adverse drug reactions. Or we could do something different. That is, here's a different drug. We know it suits you. It should not give you the side effects, and therefore that would be the option that we take. If a drug response is too weak, on the other hand, you're a so-called non-responder, we could increase the dose if it was appropriate, or the decision may be for an alternative, better suited medication for that particular indication and patient. And that's what pharmacogenomics can give us, gives us that information to make these decisions. I'm just going to take one example, clopidogrel. It's not a mental health drug, but there are a lot of people with who have had strokes and TIAs who are on this drug, who may also be on antidepressants at the same time, or anti-anxiolytics. So clopidogrel is what we call an antiplatelet agent. So platelets are little bits in the blood that float around the bloodstream, and if you cut yourself, it clogs the hole and stops you bleeding to death, essentially. But sometimes it can block off arteries in the heart, give you a heart attack. Sometimes your platelets can clot in the brain and give you a TIA or a stroke. Now, we know from data that's collected that there are about 100,000 new strokes every year in the UK. And clopidogrel, as that antiplatelet agent, is what we call a prodrug. That means it's not in its active form. It has to be absorbed in your gut. It's transported to the liver, and in the liver it's metabolized by something called the CYP2C19 and other enzymes, and it's broken down into its active form, and then it will have the effect of reducing platelet activation via a particular receptor on the platelets, and therefore reduce the risk of further thromboses. So in other words, if you've had a heart attack, if you've had a stroke, and you're put on this drug, if it works for you, it's a good drug. It reduces your risks of having another stroke, another TIA, another heart attack. We know that from studies that have been done. However, if you've got the variant that does not allow that to happen, then from my point of view, you might as well throw it down the toilet because it's not going to work. And that is really annoying. So I think from my point of view, it's about finding out, are you in that group that are in the 32% of the population of the UK in whom it doesn't work? Or are you in the 68% in whom it does, in which case you can prescribe as normal? And then you've got British South Asians. This is an ethnic group that we know that if they have clopidogrel, it doesn't work in more than half of them. So it's a toss a coin. Try that, see if it works, and if not, and you won't necessarily get side effects. You just won't know until you have the next stroke or heart attack and assume that it hasn't worked for you. So I think that is really something to bear in mind. I've just got to stop sharing my window for a minute because I can't. Yeah, something popped up on my screen. Right. So what does NICE say? So NICE, the National Institute for Health and Care Excellence, that's the government body that reviews information about drugs and medical devices. They actually wrote some guidelines last year at the end of July, which said that patients presenting on the NHS with a stroke or a TIA should have a genetic test to find out whether they can be treated with clopidogrel, which reduces the risk of further strokes. And as Mark Chapman, who was the interim director of medical technology and digital evaluation at that time, said, treatment with clopidogrel is effective in preventing further strokes for the majority of people who don't have the gene variant. However, until now, doctors have not known who cannot be treated with clopidogrel until after they've had a second stroke or TIA. So NICE have guided, this is an important thing to do, and therefore we should be doing it. We're not at the moment because there are 4 pilot sites trialing out a test for clopidogrel suitability. And until the results of those are known, the can is being kicked down the road. We're not implementing it across the whole of the NHS, but we are going to be doing it at some point, hopefully very soon, because every day that's delayed, more patients are dying, literally. I'm going to use another example around anti-anxiolytics and antidepressants. And there's been lots of research done. I'm just going to summarize a little bit of that. So in America, who are ahead of us in terms of pharmacogenomics in some ways at the moment, approximately 15% of Americans aged 65 or over have anxiety or depression. And medications for these particular diseases are amongst the highest prescribed drug classes in the USA. And it's similar in the UK. Well-established guidelines exist how to treat anxiety and depression, but these often fail due to the drugs being ineffective or because of side effects, which occur in 30 to 50% of patients prescribed them. In one study, looking at 67 patients, so relatively small study, aged between 67 and 90, primarily with anxiety, depression, or memory impairment, 46 of those patients were taking SSRIs, which are a form of antidepressant. And that amounts to 69% of them. So about 7 out of 10 patients were taking an antidepressant of that particular type. And following pharmacogenomic panel testing, particularly looking at 2 particular gene variants, which we call CYP2D6 and CYP2C19, 72%, that's just over 7 out of 10 patients, were found to have an actionable phenotype leading to a potential change in their prescriptions. That means they have something that's very relevant within their genetic variants that means that they're not on the right drug or the right dose of the drug that they are on. So 72%, 7 out of 10 were changing their prescriptions as a consequence. So a significant impact. There's a study called the ASPRI study of older patients, and this was looking at a much bigger group. Now we're looking at over 13,000 community patients aged 65 or over in the USA. Now, 98.8%, that's virtually 99 out of every 100 participants, carried at least one genetic variant that was actionable. And that was looking at just 10 so-called pharmacogenes on this in this particular study. About 60% affected this CYP2C19 gene and 41% the CYP2D6 ones. And these are 2 very important genes in the context of how our bodies deal with the medications we're given. And looking at some of the drugs in the mental health space here, amitriptyline, sertraline, escitalopram, citalopram, venlafaxine, and paroxetine, a lot of patients who are on these drugs, and the numbers are there, were changed as a consequence of having their pharmacogenetics looked at. So just taking an example, venlafaxine, 183 people on venlafaxine, 38 of them were taken off the drug after the results of this test was undertaken. That's quite significant. And then you look at sertraline, a very commonly prescribed SSRI, 58 had to change the dose of the drug they were on following the use of the pharmacogenomic testing. So quite big numbers are changing their medications as a consequence of pharmacogenomics. Looking at antipsychotics, there's another study. This was done this time in the UK and published in Recent Advances in Psychopharmacology. They were looking at CYP1A2, the CYP2D6, and CYP3A4. And this was published in May of this year, so just a month or so ago. And in that study of 453 patients, 62.9% had variants affecting the latter two genes. That's the CYP2D6 again, and this time the CYP3A4. So a lot of patients have genetic interactions with the drugs that they're potentially going to be prescribed. And that is what can then impact on adverse drug reactions or side effects. And on the other side, the benefits that we're after achieving, which is improvement in quality of life for the patients we're dealing with. So really important bits of information. And there are lots more studies, and this is just showing some of the studies that have been done in the mental health space, and there are many, many more now being published. And it's important that we all, as doctors and pharmacists, get our heads around these, and the healthcare system use this information to the advantage of the patients we care for. Now, a bit about pharmacogenomic testing. Well, what is it? So it's basically there are three types of tests, really. There's so-called panel testing. There's a lab-based test for looking at a single gene, and then there's point-of-care testing, which looks at the variants of the same gene for just one drug. So using the clopidogrel as an example, there is a point-of-care test produced by a company called GeneDrive in this country, and they have a test that can be used in the emergency setting where the patient comes in, have had a stroke or a TIA. You can do a test and have a result within 2 hours to tell you, can I give this patient clopidogrel, or are they better suited to an alternative? So that's immediate reactive testing, which can be very useful in that acute setting. What lab-based testing can do is a similar thing, but in a lab, it just takes longer to turn around. So that may be more suitable for patients who are on the drug already, where it's not immediately needed to know, can I be on it or not? But they may want to know, is this drug suitable for me? In which case you can do it if it's slightly more slowly in a lab, and then get the results and be informed. And then panel testing doesn't just look at one gene and one drug. It looks at multiple genes and multiple drugs. And in this way, we can gather a lot of information about an individual and which genes within a panel will work for them and which ones won't work for them, and which ones you need to dose adjust to make them work more effectively in them and reducing the risk of side effects. So using the Mantara pharmacogenomic panel test as an example, this is a saliva-based test. It can be blood, but we do it as a saliva test for the most part. And it can be done through the post. So we can send you the test, you spit in a tube, you register it online, you send it back to us. And we try and turn the reports around as quickly as we can using our lab. And then you get that report with all the information. And this aligns to a specific study called the UPGX Prepare study that was published in The Lancet, one of the leading journals in the world. So it's based in research and based and validated to be used, so that patients can be confident in the report they get, and the doctors reading that report will be confident to use that information to guide the prescriptions. We are unique in the UK insofar that we were the first UKCA marked pharmacogenomic provider with a CE mark, aligned with the UPGX Prepare study and fully registered with the MHRA. The MHRA is the Medicine and Healthcare Products Regulatory Agency, and it's the body that you have to be aligned to from a safety perspective. We are a medical device, and it is classified as a Class 1 medical device under the UK and EU regulations. And we meet global standards for data security and medical device regulation. So I think particularly around data protection, we have lots of safeguards in place, and each person's data is personal to them, and it's not something that we're going to be selling anytime soon, unlike 23andMe, who's got into a bit of trouble, as everybody knows. So the future of pharmacogenomics. Well, pharmacogenomics depends on quality standards, and great strides have been made over the last several years. Regulatory inconsistency and lack of standardization has been problematic, and there have been variable lab practices. There's been confusion among some of the doctors and consequently some risks to patient safety. However, in America, in October of last year, there was a standardizing laboratory practices in pharmacogenomics, so-called STRIPE consensus conference, and that looked at all the evidence out there genetically, so that any company, like including ourselves, should only use very relevant so-called actionable information, and not everything else that's just noise and just confuses and confounds the people looking at it and trying to understand it. In the UK, there is something called CERSI, CERSI, that has been brought together, and it is the community of pharmacogenomics, from the labs to the IT people to the regulators to companies like ourselves to the NHS, that are involved in trying to work out how are we going to implement pharmacogenomics across the UK within the NHS, and use standards like those that have been defined by Stripe in the USA. We're going to be defining our own in the UK, and that work is ongoing now. Indeed, I was at a workshop yesterday, and I'm at a workshop tomorrow with this in mind. The mission is to bring transparency, clinical relevance, and trust to those who are using pharmacogenomic testing. And until it's available on the NHS more broadly, and understanding that the PREPARE study is the largest randomized trial of pharmacogenomics in the world and is a validated test algorithm, that is the basis of the Mantara test that we do. So, pharmacogenomics is a compelling priority for health systems around the world, not least the NHS. In the NHS, last year was set up the NHS England Network of Excellence for Pharmacogenomics and Medicines Optimization. Bit of a mouthful, but it's about trying to work out giving the right medications to the right patients. The PROGRESS study in Manchester, which I spoke about above, which has already shown that 28% of people, possibly more, on those 4 groups of drugs, including antidepressants, were changing their prescriptions after their profiles were checked. And then the Centre for Excellence in Regulatory Science and Innovation in Pharmacogenomics, the CERSI thing I mentioned just now, is going to create UK-specific guidance and to clarify the complex regulatory pathways, so that providers will have to be there to follow the rules, as it were, and ourselves included in that. And in the meantime, we are a trusted private provider, and we are bridging the gap between when it's on the NHS and at the moment when it's not. But hopefully we will be integrated in that whole system when it's all worked through. So in summary and conclusion, pharmacogenomics will soon be the new standard of care and will lead to safer prescribing. It will improve health outcomes, and especially in the area of mental health, where there is a massive need in this country at the moment. The near future is likely to see a combination of point of care testing and panel testing, with the latter most relevant to the more holistic care of patients with mental health disorders. The evidence is mounting as to both the cost effectiveness of and the cost savings related to pharmacogenomics, and it will likely save many billions for the healthcare and wider economies within a year. So that's why it's important for the politicians to get their heads around it and start working with us to make important and quick decisions. The carbon impact of pharmacogenomic guided prescribing and reduced polypharmacy, fewer adverse drug reactions, and improved outcomes will be significant as we make the whole healthcare system more efficient and effective for the patients that are demanding the care from us. The challenges now, as I alluded to earlier, are around education and awareness. It's also then about implementing the testing within the healthcare systems that we have. And there are challenges ahead before we can achieve all of these goals. But the imperative is there to drive awareness, education, partly why I'm talking today, to patients, but also to doctors. And we need to focus on ensuring that pharmacogenomics remains equitable, both regarding future research and in implementation. We need a mindset change and a behaviour shift from patients on the one hand and from doctors on the other. They both need to happen, and each day of delay until we implement pharmacogenomics is costing lives. The NHS does hide behind its walls somewhat and can be unwittingly stifled by well-meaning academics, and we need to bridge this gap between innovation and implementation. We need to shorten that space because the innovation is there. Implementing it is the challenge and the opportunity, and the longer it's delayed, the more people are losing their lives or their life qualities and not being managed in the efficient way that we know pharmacogenomics can impact. We need to embrace pharmacogenomic panel testing now in our imperfect system, not try and work out the perfect system, use it, and then we can start to make it work better for all of us as we stumble along, finding out the best way to do it. I use the analogy of learning to drive a car. You don't need to be a mechanic, know what's under the bonnet, And you certainly can't drive the car if you're sat in the lay-by. You need to know the basics. I know how to start it. I know how to put it into gear. I know how to use mirrors, etc. So basics, you don't need to be an expert, in the same way that to use pharmacogenomic results, you don't need to be a geneticist. You can be any doctor, any pharmacist, anyone who has some training to use that information to guide their prescribing. We don't want to be sat in the lay-by. We want to be out on the road driving imperfectly, understanding it. And if you want to get your head under the bonnet, you can do that later on. It's not important at the beginning. The important thing is to start driving, start using pharmacogenomic testing, using the information to help our patients. Hiding behind ignorance is not acceptable, and nor should it be. We have an ethical duty to our patients to provide the best evidence-based care we can, and the evidence is growing, and we can no longer accept not embracing what pharmacogenomics has to offer, both for ourselves and particularly for our patients. Thank you very much. Now, what does this mean? Well, the idea is I want to empower patients with their reports and the doctors who are going to read those reports in precision medicine, personalizing the care journey that patients get. We want to improve patient outcomes. We want to statistically significantly reduce the problems associated with the current trial and error prescribing pathway. We want to enhance decision-making, and data-driven medication choices are a tool to that end. So be empowered by the information. You can go to your doctor and say, I've had this test, I'm on this drug, I'm not sure it's right for me. Can you look at this and let's discuss it? That is the way forward. And I empower everybody to start thinking about this important tool to use and to be excited about, because it is exciting. Thank you very much. If you have any questions, then please do not hesitate to ask any. I'd be very happy. I'm going to stop sharing my screen so you can stare at my live face instead. And hopefully that has been helpful to you. Any questions? If there aren't any questions, I would like to end this presentation, and I hope you enjoyed what you heard, and hopefully you'll be inspired to start thinking about pharmacogenomics going forward. Many thanks.